Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. This module section offers a fundamental overview necessary for understanding the clinical use and therapeutic framework of modern biological products. The use of key biologic types, including monoclonal antibodies, mAbs, fusion proteins, cytokines, and vaccines, requires a solid grasp of their specific mechanisms of action, which often influence complex signaling pathways and cellular interactions that control the human immune system. A main educational goal is to distinguish the use of biologics from traditional small molecule therapy in patient cases. Biologic products are fundamentally different from small molecule agents in their structure, mechanism of action, and pharmacological features, as they are typically large, complex molecules produced in living systems using recombinant DNA technology. This difference is vital in advanced therapeutics. In the field of advanced therapeutics, having a comprehensive understanding of complex biological agents is essential for pharmacy practice. This text introduces 10 key learning objectives aimed at enhancing your understanding of biological drugs, foundational immunology, and how these agents differ from small molecule medications. First, it is important to distinguish between biologics and small molecules. Biological therapies, such as monoclonal antibodies and cytokines, are derived from living systems, whereas small molecule drugs are synthesized chemically. These biologics are generally larger in molecular size, exhibit inherent variability, and have unique pharmacokinetic properties, including their half-life and method of administration. Next, understanding the immune system's organizational structure is fundamental. The immune system is divided into innate immunity, which is nonspecific and not triggered by antigens, and adaptive immunity, which is specific and has memory. Key components include B lymphocytes, which mediate humoral immunity through antibody production, and T lymphocytes, responsible for cellular immunity. Assessing how monoclonal antibodies work involves examining their multiple mechanisms of action. These agents can directly inhibit receptors or ligands, induce cell death through apoptosis, and indirectly recruit immune responses. They do this by engaging host immune functions via mechanisms such as antibody-dependent cell-mediated cytotoxicity and complement-dependent cytotoxicity. Analyzing targeting strategies reveals differences between biologics and small molecule therapies. Monoclonal antibodies typically target extracellular receptors or ligands, whereas small molecule targeted therapies often inhibit intracellular enzymes by blocking specific enzymatic sites or ADP binding domains. Fusion proteins represent another class of biologics. These molecules can function as soluble decoy receptors, trapping ligands or cytokines, or act as immune co-stimulation blockers. An example includes soluble decoy receptors, like etanercept, which inhibit cytokines, and immune co-stimulation blockers such as abatacept. Cytokines, which are signaling proteins within the immune system, operate through complex networks characterized by redundancy and pleiotropism. They signal through pathways involving the Janus kinase and signal transducer and activator of transcription proteins, which relay information from the cytokines to the cell nucleus. Insulin, a well-known therapeutic protein, is classified as a biologic. There has been a regulatory transition that facilitated the development and interchangeability of biosimilar insulin products. These developments are tracked by the Food and Drug Administration in the Purple Book database. Vaccines work by inducing immunological memory, and modern vaccine platforms utilize various antigen exposure methods and adjuvants to enhance the immune response. Recombinant proteins, viral vectors, and messenger RNA are examples of current technologies that stimulate adaptive immunity by activating toll-like receptor signaling pathways. Cellular immunotherapy involves modifying immune cells outside the body to target and destroy malignant cells. For example, chimeric antigen receptor T-cell therapy involves extracting T cells, genetically modifying them to recognize specific cancer cell markers, and then reintroducing them into the patient. This approach operates independently of human leukocyte antigen compatibility. Finally, it is crucial to recognize the different toxicity profiles associated with these therapies. Biologics can cause immune-mediated adverse events, such as cytokine release syndrome, while small molecule-targeted agents may lead to target-specific toxicities like hypertension caused by vascular endothelial growth factor inhibition. The clinical use of major biological classes, such as monoclonal antibodies, fusion proteins, cytokines, and vaccines, depends on a foundational understanding of the complex signaling pathways and cellular interactions that regulate the human immune system. This immune system is characterized by a diverse range of antigen recognition capabilities, immune memory, and tolerance to the body's own tissues, which collectively protect against pathogens and disease. The immune system operates through two interconnected components: innate immunity and adaptive immunity. These two arms work together to identify, respond to, and remember various threats, ensuring the body's continued health and protection. The innate immune system serves as the host's first line of defense, operating prior to infection and characterized by responses that are not specific to any particular antigen. It utilizes germline-encoded pattern recognition receptors to identify highly conserved components of pathogens known as pathogen-associated molecular patterns. Key cells involved in the innate immune response include macrophages, dendritic cells, natural killer cells, neutrophils, eosinophils, basophils, and epithelial cells. These cells work together to detect and eliminate invading pathogens. For example, macrophages and neutrophils can phagocytose bacteria, effectively engulfing and destroying these microorganisms. Natural killer cells recognize and target virus-infected cells or tumor cells, especially those that have reduced the expression of major histocompatibility complex class I molecules. Additionally, components such as the complement system contribute to pathogen elimination through processes like cell lysis and opsonization, which marks pathogens for destruction. Adaptive immunity is activated when the innate immune response is insufficient. It provides highly specific, learned, and memory-based responses that enhance the body's ability to fight pathogens. One component of adaptive immunity involves B lymphocytes, also known as B cells, which play a crucial role in humoral immunity. These cells produce antibodies, also called immunoglobulins, which are specialized proteins that recognize and bind to specific antigens on pathogens. The binding of antibodies to antigens facilitates the removal of the pathogens from the body. This can occur through different mechanisms. Antibodies may neutralize the pathogen directly, act as opsonins to promote phagocytosis by immune cells, or activate the complement system to destroy the pathogen. T lymphocytes, also known as T cells, originate from the thymus gland and play a crucial role in mediating cellular immune responses. Among these, helper T cells are characterized by the presence of a specific surface protein called CD4+. These cells primarily regulate the functions of other immune cells, including T cells and B cells, through the production of signaling molecules known as cytokines. There are several subsets of helper T cells, each with distinct roles. For instance, T helper type 1 cells produce interferon gamma and interleukin-2, which are essential for driving cell-mediated immunity. In contrast, T helper type 2 cells secrete interleukins 4, 5, 6, and 10, which promote B-cell proliferation and antibody production. Additionally, there is a subset known as T helper type 17 cells that recruit other immune cells like leukocytes and contribute to the development of autoimmune diseases. Cytotoxic T cells, which are characterized by the absence of CD4 but express CD8, are responsible for killing tumor cells and cells infected by pathogens. These cells recognize specific antigens on the surface of infected or malignant cells and induce their destruction, playing a vital role in immune defense. Antigen presentation is a crucial process in the adaptive immune response. It involves specialized cells known as antigen-presenting cells, which include dendritic cells, macrophages, and B cells. These cells process antigens into smaller peptide fragments and present them to T cells by binding the peptides to major histocompatibility complex molecules, specifically class I and class II molecules. Activation of T cells requires two distinct signals. The first signal occurs when the T cell receptor engages with the complex of the major histocompatibility molecule and the peptide. The second signal involves the binding of co-stimulatory molecules, such as CD80 or CD86, to receptors on the T cell. These two signals together ensure proper T cell activation and subsequent immune response. Cytokines are soluble proteins that are essential for regulating the growth, development, and activation of immune cells, as well as mediating inflammatory responses. Chemokines, also known as chemotactic cytokines, are small, secreted proteins that signal through G-protein-coupled receptors to direct the migration and localization of white blood cells. These chemokines play a crucial role in immune surveillance, inflammation, and disease processes such as cancer. Interleukins and interferons are also examples of cytokines. They often exhibit redundancy, meaning different cytokines can have similar functions, and pleiotropism, where one cytokine can act on many different cell types. Signal transduction involving cytokines frequently occurs through the Janus kinase, signal transducer, and activator of transcription pathway. When cytokines bind to their receptors, they cause the receptor subunits to align, which activates the associated Janus kinases. These kinases then phosphorylate the receptor, enabling downstream signaling. Signal transducer and activator proteins bind to these phosphorylated receptors, become phosphorylated themselves, and translocate to the nucleus. There, they modify gene expression to affect cellular responses. Chemokines are important for directing the migration and localization of white blood cells through signaling via G-protein-coupled receptors. They are central to the processes of inflammation and immune surveillance. Insulin is a prime example that connects the historical development of pharmaceutical regulation with the contemporary understanding and therapeutic application of biologics. This demonstrates the importance of having a comprehensive understanding of different biologic classes in pharmacy practice. Insulin falls distinctly into the category of therapeutic biologic products because of its composition and manufacturing process. Insulin is classified as a hormone and as a therapeutic protein. It is a protein-based drug that, similar to other biologics, naturally occurs in the human body. However, in patients with deficiencies, such as those with insulin-dependent diabetes, insulin is administered therapeutically. The manufacturing process further distinguishes insulin from small molecule drugs. While small molecule drugs are generally low in molecular weight and produced via chemical synthesis, biological products like insulin are typically large, complex molecules. They are produced in living systems, such as microorganisms or animal cells, through recombinant DNA technology. The section titled Regulatory Transition and Implications of Biosimilars discusses the recent regulatory changes affecting insulin and how these changes influence its clinical management. Insulin plays a crucial role in the therapeutic landscape, and understanding its regulatory history is key to comprehending its current usage. In the past, insulin was classified and regulated as a chemical or small molecule drug, despite the fact that it is produced from living cells. This historical classification has implications for its regulation and development. The recent regulatory transition signifies a shift towards recognizing the biological nature of insulin, which may impact future therapeutic approaches and biosimilar development. The regulatory landscape for insulin and other therapeutic proteins has shifted, now falling under the biologics pathway established by the Public Health Service Act, Section 351, because these products meet the definition of biological products. This transition has opened up new opportunities for manufacturers to submit applications for biosimilar and interchangeable biosimilar insulin products through the abbreviated pathway known as the Section 351(k) pathway. The first interchangeable biosimilar insulin was approved in the summer of 2021. With the approval of these interchangeable biosimilar insulins, such products can potentially be substituted for the original reference product without the need for intervention by the prescribing healthcare provider, depending on the state pharmacy laws. This is similar to the way generic small molecule medications are substituted. Insulin is a hormone that plays a crucial role in regulating blood sugar levels. Its function and associated pathologies, such as insulin resistance, are closely linked to the activity of cytokines, which highlights the complexity of biological interactions within the body. Cytokines are soluble proteins that are essential for the body's immune and inflammatory responses. Abnormal glucose and lipid metabolism are significantly affected by cytokines secreted by various organs. For instance, adipose tissue produces adipokines, the liver secretes hepatokines, and muscles release myokines. These cytokines influence metabolic processes and are integral to understanding the broader impacts of insulin and cytokine interactions in health and disease. Negative regulators, such as pro-inflammatory cytokines, play a significant role in the development of insulin resistance in individuals with type 2 diabetes. Many inflammatory cytokines directly interfere with insulin signaling pathways. For instance, tumor necrosis factor alpha functions as a mediator of insulin resistance by partially obstructing insulin action through direct effects on the insulin signaling process. Interleukin-1 beta, another cytokine, reduces the uptake of glucose stimulated by insulin, decreases the process of fat synthesis, and downregulates the expression of insulin receptor substrate 1. Elevated levels of interleukin-1 beta are commonly observed in individuals with type 2 diabetes. To counteract the harmful activity of these cytokines, fusion proteins such as rilonacept are utilized. These proteins work by inhibiting the activity of pathogenic cytokines, specifically targeting interleukin-1 activity. Insulin functions as a key therapeutic biologic, a recombinant protein hormone, whose regulatory status has evolved to incorporate biosimilar strategies. While its efficacy is often challenged by the pathogenic signaling mediated by other cytokine biologics. Information regarding approved insulins, including biosimilar and interchangeable biosimilars, is maintained in the FDA's Purple Book database. The distinction between biologic products and small molecule targeted agents is a fundamental concept in advanced therapeutics. This difference is based on various factors, including their molecular structures, origins of manufacture, mechanisms of action, and resulting pharmacokinetic profiles. Understanding these differences is essential for experts in the field, as it influences decisions regarding treatment options and drug development. Biologic products, such as monoclonal antibodies and cytokines, are generally large, complex molecules like proteins, antibodies, and growth factors. They range from a few hundred to several 100,000 Daltons in molecular size. These products are manufactured in living systems using recombinant DNA technology and naturally exhibit inherent variability between production lots due to processes such as post-translational modifications that occur in living cells. In contrast, small molecule targeted agents have a low molecular weight, typically less than 1,000 Daltons. They are manufactured synthetically from chemicals, ensuring that their active ingredients are consistent within and across different production lots. The complex structure and manufacturing process of biologics, such as therapeutic proteins and monoclonal antibodies, make them difficult to purify, process, and manufacture. Minor structural differences, such as changes to the glycosylation patterns, can naturally occur during the production of biologics. This inherent variability requires biosimilar manufacturers to demonstrate that their products display similar patterns and types of variations compared to the reference product in order to support claims of biosimilarity. The scope and nature of targeting represent a significant functional distinction. Small molecule agents designed to target intracellular components typically work by halting the progression of cancer through the blockade of abnormal signaling pathways within cells. These agents are engineered to penetrate cellular membranes and commonly function as kinase inhibitors. They operate by binding to the adenosine triphosphate binding domain of enzymatic proteins known as kinases, which are responsible for transmitting signals inside the cell. A common outcome of this mechanism is that most approved kinase inhibitors target multiple enzymatic sites. This broad spectrum of activity can lead to unintended effects or toxicities. For instance, targeting the vascular endothelial growth factor family is often associated with adverse effects such as high blood pressure, delayed wound healing, and protein in the urine. Biologics targeting extracellular components primarily include monoclonal antibodies, which are the most common form of biologic therapy. These antibodies are typically specific to a single receptor and work by targeting extracellular receptors or their natural ligands. Their mechanism involves preventing ligand binding, which in turn inhibits the activation of downstream intracellular signaling pathways. For instance, cetuximab is a chimeric monoclonal antibody that blocks epidermal growth factor ligands from binding to the epidermal growth factor receptor. In addition to directly blocking these interactions, monoclonal antibodies can also facilitate the destruction of tumor cells by recruiting immune components. This can occur through mechanisms such as complement-dependent cytotoxicity or antibody-dependent cell-mediated cytotoxicity. Moreover, monoclonal antibodies are utilized to deliver toxic substances directly to tumor cells, a strategy known as antibody-drug conjugates. The difference in target location means that even when focusing on the same pathway, such as the epidermal growth factor receptor, there are different types of inhibitors. Small molecule inhibitors, like erlotinib and gefitinib, work by attacking the intracellular tyrosine kinase function. In contrast, monoclonal antibodies, such as cetuximab and panitumumab, bind to the extracellular domain of the receptor. The physical size and complexity of biologic medications significantly influence how they are processed by the body. This is in stark contrast to small molecule drugs. Small molecule agents are characterized by their relatively small size and common metabolism through the cytochrome P450 system. As a result, they typically have shorter half-lives, often ranging from 12 to 24 hours. These drugs are usually administered orally, once or twice daily. Biologic products such as monoclonal antibodies often have a long plasma half-life, sometimes lasting several weeks. For example, bevacizumab has a half-life of 4 weeks. This extended half-life allows these drugs to be administered only intermittently. Most biologic agents, which include proteins and nucleic acid-based drugs, cannot be taken orally because of their large size and instability within the gastrointestinal tract. Instead, they are typically administered through parenteral routes, such as intramuscular or intravenous injections. Their substantial size usually results in a smaller volume of distribution, as they tend to remain confined to the vascular system or extracellular fluid. Since these biologics are primarily eliminated through mechanisms independent of the cytochrome enzymes, they are less likely to interact with other drugs in ways that small molecule drugs might. These critical distinctions necessitate different approaches in clinical monitoring, patient education, stability management, and biosimilar development, which must assess these complex molecular properties, often referred to as quality attributes. Both classes may target the same signaling pathway, such as the epidermal growth factor receptor. However, they often display different ranges of antitumor activity. This variation is due to their distinct binding sites, with some binding extracellularly and others intracellularly. The clinical use of monoclonal antibodies depends on their highly specific and multifunctional mechanisms of action, which utilize the body's natural immune system to achieve therapeutic objectives. These biological products are generally large, complex molecules, often belonging to the immunoglobulin G class, and are produced using living systems. Their high specificity for a single antigenic determinant allows these antibodies to serve as precise targeting agents. The mechanisms through which monoclonal antibodies exert their effects can be broadly categorized into direct actions, such as blocking signals or inducing cell death, and indirect actions, including recruiting immune cells and delivering cytotoxic substances. Monoclonal antibodies are often engineered to interfere with intracellular signal transduction pathways, by targeting components outside the cell. One way they do this is through receptor and ligand inhibition. The Fab region of a monoclonal antibody binds specifically to a target antigen on the surface of cells or to soluble ligands. For example, it can bind to extracellular receptors such as epidermal growth factor receptor or human epidermal growth factor receptor 2, or to circulating growth factors like vascular endothelial growth factor. By binding to these targets, the monoclonal antibody prevents the ligand from attaching to the receptor, thereby blocking the receptor's activation and subsequent dimerization. This interruption inhibits the signals that promote cell growth and survival, ultimately reducing cell proliferation. Additionally, monoclonal antibodies can induce apoptosis directly. When the antibody binds to a targeted cell, it can activate signals across the cell membrane that lead to programmed cell death, helping to eliminate abnormal or cancerous cells. A key feature of therapeutic monoclonal antibodies is their ability to activate the body's innate immune mechanisms through the constant region, also known as the Fc region. One important process is antibody-dependent cell-mediated cytotoxicity, which involves the Fc portion of the antibody that is bound to a target antigen. This Fc region recruits immune effector cells, such as natural killer cells, monocytes, and macrophages, which possess Fc receptors on their surfaces. When these effector cells bind to the Fc region of the antibody coating the target cell, such as a tumor cell or a cell infected by a microbe, they become stimulated to destroy or lyse the target cell. Another mechanism is complement-dependent cytotoxicity. Here, the binding of the Fc region of the antibody activates the complement system, a series of plasma enzymes and effector proteins that work together to destroy target cells. Specifically, the Fc region of the antibody interacts with components of the complement system, leading to the lysis of the target cell. For example, certain regions of immunoglobulin G and immunoglobulin M antibodies are involved in binding to complement proteins during the activation of the classical complement pathway. Monoclonal antibodies can serve as advanced targeting agents, enabling treatments that are not possible with small molecules alone. One such application involves immunoconjugates, which include antibody-drug conjugates, radioimmunoconjugates, and immunotoxins. These antibodies can be used to deliver toxic agents specifically to cells expressing certain antigens. For example, antibody-drug conjugates consist of an antibody bound to a chemotherapy drug. When the antibody attaches to a tumor cell's surface antigen, the complex is taken into the cell through receptor-mediated endocytosis. Inside the cell, the complex is transported to lysosomes where it is broken down, releasing the active drug to induce cell death. This targeted approach aims to limit exposure of healthy tissues to the toxic agents, thereby improving the overall safety and efficacy of the treatment. Another important application of monoclonal antibodies is in immune checkpoint inhibition, a form of immunotherapy. These antibodies work by blocking inhibitory interactions between receptors and ligands that tumors use to evade immune detection. For instance, some monoclonal antibodies target cytotoxic T lymphocyte-associated protein 4, while others inhibit programmed cell death protein 1 or its ligand. By blocking these inhibitory pathways, the antibodies prevent the suppression of activated T cells. This allows T cells to remain active and proliferate, enhancing the immune system's ability to attack and eliminate cancer cells. Monoclonal antibodies are specialized laboratory-produced molecules designed to target specific classes of molecules for clinical treatment. One important class of these antibodies includes cytokine inhibitors, particularly those directed against tumor necrosis factor alpha. Examples of such agents are adalimumab, marketed under the name Humira, and infliximab. These medications work by binding to and neutralizing the pro-inflammatory cytokine tumor necrosis factor alpha, making them useful in treating conditions like rheumatoid arthritis, psoriasis, Crohn's disease, and ankylosing spondylitis. Another significant class involves agents that target B cells, specifically through the cell surface protein CD20. Rituximab, sold as Rituxan, and ocrelizumab are two such monoclonal antibodies. They bind to CD20 on B cells, leading to cell destruction through mechanisms known as complement-dependent cytotoxicity and antibody-dependent cellular cytotoxicity. These therapies are utilized in the treatment of non-Hodgkin lymphoma, chronic lymphocytic leukemia, and multiple sclerosis. Immune checkpoint inhibitors, such as durvalumab, avelumab, and relatlimab, work by preventing activated T cells from being suppressed by tumors, which enhances their ability to fight cancer. These therapies are clinically applied in cases of metastatic melanoma and various other carcinomas. Anti-angiogenesis agents, exemplified by bevacizumab, target the circulating vascular endothelial growth factor. By inhibiting this factor, these agents prevent the formation of new blood vessels within tumors, a process known as angiogenesis. This strategy is used in treating a variety of solid tumors. Finally, antibody-drug conjugates are specialized therapies that use highly selective monoclonal antibodies to deliver potent cytotoxic drugs directly to tumor cells that express specific antigens. Examples include trastuzumab emtansine and brentuximab vedotin, which enable targeted destruction of cancer cells while minimizing harm to normal tissues. The development and clinical application of fusion proteins represent a sophisticated strategy in modern biopharmaceutical science, leveraging the modular nature of protein structure to create novel therapeutic agents. As a distinct class of biologics, fusion proteins are structurally engineered molecules that typically combine functional segments from two or more different proteins to yield enhanced pharmacokinetic properties or novel mechanisms of action. The primary general mechanisms employed by therapeutic fusion proteins fall into several key categories, often centered around receptor mimicry and targeted biological activity. A highly successful application of fusion protein technology involves creating soluble proteins known as decoy receptors. These decoy receptors are designed to intercept circulating ligands or cytokines, which prevents them from activating their natural, membrane-bound receptors. This strategy effectively neutralizes pathogenic signaling, offering a powerful means to modulate biological responses. The mechanism of action involves a protein domain that is responsible for binding to a specific target ligand, such as a cytokine or growth factor. This protein domain is fused to the fragment crystallizable portion of an immunoglobulin, which is often derived from human immunoglobulin G1. The fragment crystallizable region typically provides enhanced stability to the fusion protein and extends its half-life in the bloodstream. Clinical examples. Etanercept is a therapeutic agent designed as a fusion protein combining the tumor necrosis factor alpha receptor with the constant fragment of immunoglobulin G. Its primary function is to bind and neutralize the pro-inflammatory cytokine tumor necrosis factor alpha, thereby inhibiting pathogenic cytokine activity. This medication is used to treat inflammatory conditions such as rheumatoid arthritis. Zivaflobercept, also known as vascular endothelial growth factor trap, is a soluble recombinant fusion protein. It is engineered by fusing sections of vascular endothelial growth factor receptors 1 and 2 with the constant fragment of human immunoglobulin G1. Its mode of action involves sequestering vascular endothelial growth factors A and B, as well as phosphatidylinositol glycan biosynthesis class F. By trapping these ligands before they can interact with their native transmembrane receptors, zivaflobercept reduces proangiogenic signaling, which can help inhibit tumor growth. Rilonacept is a dimeric fusion protein composed of the ligand-binding domains of the extracellular portions of the human interleukin, 1 receptor component, and the interleukin, 1 receptor accessory protein. These components are fused to the Fc portion of human immunoglobulin G1. Rilonacept is used in the treatment of cryopyrin-associated periodic syndrome. Anakinra, on the other hand, is not a fusion protein of the Fc portion. It is a recombinant form of the natural interleukin, 1 receptor antagonist. Anakinra works by preventing interleukin, 1 from binding to its receptor, thereby interrupting the cascade of cytokines that leads to inflammation. Fusion proteins can be designed to interfere with the necessary co-stimulatory signals required for full T-cell activation, serving as a powerful form of immunosuppression. The mechanism of action typically involves fusing a key T-cell inhibitory molecule, such as cytotoxic T lymphocyte-associated protein 4, to the fragment crystallizable region of an antibody. This mimicry allows the fusion protein to bind to essential activation ligands, like CD80 or CD86, on antigen-presenting cells. By doing so, it prevents the T-cell receptor signal from progressing to full T-cell activation. Clinical examples. Abatacept and belatacept are recombinant fusion proteins. They consist of the extracellular domain of cytotoxic T lymphocyte, associated antigen 4, fused to the Fc domains of human immunoglobulin G1. These proteins work by binding to CD80 and CD86 molecules on dendritic cells. This binding prevents the activation of T cells by blocking the activating signal usually provided by CD28. As a result, these medications are useful in treating rheumatoid arthritis and in preventing the rejection of kidney transplants. Targeted toxin delivery through immunotoxins involves the fusion of a targeting domain, such as a variable region derived from an antibody or a cytokine, with a cytotoxic payload, which is typically a fragment of a bacterial toxin. These fusion proteins work by specifically binding to receptors that are overexpressed on the surface of target cells, such as tumor cells. Once binding occurs, the entire complex is internalized into the cell, where the toxic fragment is released inside. This release inhibits essential metabolic functions within the cell, ultimately leading to programmed cell death or apoptosis. This mechanism allows for highly selective destruction of diseased or unwanted cells, minimizing damage to surrounding healthy tissues. Clinical examples include denileukin diftitox, also known as ONTAC. This immunotoxin is created through genetic recombination of interleukin-2, a signaling protein for immune cells, and the active fragment of diphtheria toxin. It specifically targets the high-affinity interleukin-2 receptor. Once the diphtheria toxin fragment enters the cells, it inhibits protein synthesis by modifying a key elongation factor, leading to cell death. Denileukin diftitox is approved for treating recurrent or refractory cutaneous T-cell lymphomas. Another example is moxetumomab pasudotox, which is a cytotoxin directed against the CD22 receptor. It is composed of a recombinant murine immunoglobulin variable domain fused with a truncated form of Pseudomonas exotoxin. The exotoxin functions by inhibiting protein synthesis through the adipyribosylation of the elongation factor 2, ultimately resulting in cell death. Angiogenesis inhibitors, such as zivaflobercept, are used in cases of resistant or progressing metastatic colorectal cancer when combined with chemotherapy. These inhibitors work by fusing domains of vascular endothelial growth factor receptors 1 and 2 to the fragment crystallizable region of a human immunoglobulin G1 antibody. This fusion protein traps vascular endothelial growth factors A and B, among others, preventing them from binding to their native receptors and thereby inhibiting the formation of new blood vessels. Immune modulators like abatacept and belatacept are used to prevent rejection in kidney transplant patients and to treat rheumatoid arthritis. These drugs are designed as fusion proteins that include cytotoxic T lymphocyte-associated protein 4 linked to the fragment crystallizable region of a human immunoglobulin. They work by binding to CD80 and CD86 molecules on antigen-presenting cells, which blocks the co-stimulatory signal required for T-cell activation. This mechanism helps to suppress unwanted immune responses that could lead to transplant rejection or autoimmune disease. Denileukin diftitox is an immunotoxin that targets interleukin-2. It is used to treat recurrent or refractory cutaneous T-cell lymphomas that express the CD25 marker. The medication's interleukin-2 component directs fragments of diphtheria toxin to cells that possess the high-affinity interleukin-2 receptor, also known as CD25. This binding inhibits the synthesis of proteins within these cells, leading to their destruction. Another medication, anakinra, is used to treat rheumatoid arthritis. It is a recombinant form of a natural antagonist of the interleukin-1 receptor. By preventing interleukin-1 from binding to its receptor, anakinra helps to halt the cytokine cascade that contributes to inflammation and joint damage in rheumatoid arthritis. Receptor Fc fusion proteins, such as etanercept, are used to treat inflammatory diseases. This medication is a recombinant, soluble receptor for tumor necrosis factor alpha, fused to a segment of human immunoglobulin. It works by inhibiting the activity of cytokines that contribute to inflammation. Cytokines are essential signaling proteins that play a crucial role in orchestrating both the innate and adaptive immune responses. These proteins include interferons and interleukins, which are produced by a wide variety of cell types, such as white blood cells. Their primary functions involve regulating the growth, development, and activation of immune system cells, as well as mediating inflammatory responses. Understanding the highly complex, often redundant, and pleiotropic regulatory functions of cytokines is fundamental to grasping their clinical applications. The mechanisms by which cytokines operate are core to their role in immune system regulation, highlighting their importance in maintaining immune homeostasis and responding to various pathological challenges. Cytokines influence target cells by binding to specific receptors on their surface. This interaction operates in a manner similar to that of hormones. When cytokines bind to these receptors, they activate genes within the cells. This gene activation leads to various cellular responses, including cell activation, growth, and differentiation. Additionally, it prompts the expression of specific functional molecules on the cell surface and enhances the cell's effector functions. The initiation of cell signaling often involves the Janus kinase, signal transducer and activator of transcription pathway, especially for receptors that are part of the hematopoietic growth factor family. When cytokines or growth factors attach to their receptors on the cell surface, this prompts the receptor subunits to come close to each other. This proximity allows the associated Janus kinases, such as Janus kinase 1, Janus kinase 2, Janus kinase 3, and tyrosine kinase 2, to phosphorylate each other and become activated. Once activated, these kinases phosphorylate tyrosine residues on the receptor subunits, creating specific sites where signal transducer and activator of transcription proteins can bind. These proteins then attach to the receptors, become phosphorylated, and move into the nucleus of the cell, where they influence gene expression. The cytokine system is characterized by two key properties that contribute to its complex network structure. One of these properties is redundancy, which refers to the fact that different cytokines often have similar biological functions. The other property is pleiotropism, meaning that many cytokines can act on multiple distinct types of cells. This broad range of effects is due to the expression of the same cytokine receptors on various cell types, which leads to the formation of extensive cytokine networks. Modes of signaling and cytokine communication involve three primary mechanisms. In autocrine signaling, a cell secretes cytokines that act upon the same cell, affecting its own behavior. Paracrine signaling occurs when cytokines are released by a cell and influence nearby target cells, enabling localized communication. Endocrine signaling involves the secretion of cytokines into the systemic circulation, allowing them to travel distantly and act on target cells far from their original source. These modes of action facilitate diverse and complex intercellular communication within biological systems. Chemokines, also known as chemotactic cytokines, are a large family of small, secreted proteins. They primarily function as essential organizers of cell movement and trafficking within the body. These proteins are best recognized for their role in stimulating the migration of cells, particularly white blood cells or leukocytes. Chemokines play a central role in immune system development, maintaining homeostasis and mediating immune and inflammatory responses. They direct various types of cell movement, including chemotaxis, haptotaxis, chemokinesis, and haptokinesis. Additionally, chemokines can induce cell arrest or promote cell adhesion. Chemokines propagate their signals through receptors located on the surface of cells. These receptors are part of a family of 7 transmembrane domain proteins that belong to the G protein-coupled receptor group. Conventional chemokine receptors typically activate by engaging with specific G proteins, particularly the G-alpha, IgG, subtype. This activation also involves the recruitment of beta-arrestins, which help regulate receptor activity. The signaling pathways initiated by these interactions lead to various cellular responses, including cell migration and adhesion, as well as other biological processes. Chemokines are significantly influenced by their interactions with the extracellular matrix and by various post-translational modifications. Glycosaminoglycans, a type of carbohydrate molecule, play a key role in regulating chemokine binding. This interaction impacts the distribution of chemokines within tissues as well as their stability and half-life. Additionally, chemokines are regulated by specific enzymes known as proteases. These enzymes can cleave the chemokines at their amino terminal end, which can alter their affinity for receptors or even change their function from activating to blocking receptor activity. Such modifications are crucial for fine-tuning the immune response and ensuring proper cellular signaling. Type 1 interferons, such as interferon alpha and interferon beta, bind to the same receptor known as interferon alpha/beta receptor. This binding promotes antiviral activity, inhibits cell proliferation, and increases the expression of major histocompatibility complex class I molecules. Specifically, interferon beta may decrease antigen presentation in the nervous system by counteracting the induction of major histocompatibility complex molecules in glial cells. Clinically, interferon alpha is used to treat various types of tumors, as well as hepatitis B and C infections. Interferon beta, on the other hand, is approved for the treatment of relapsing multiple sclerosis. Type 2 interferon, which is interferon gamma, binds to a different receptor. It enhances immune function by stimulating T cells, macrophages, and natural killer cells. Interferon gamma is unique among interferons because it can induce the expression of major histocompatibility complex class II molecules. Additionally, it can increase the expression of tumor necrosis factor alpha receptors. Its clinical application includes the treatment of chronic granulomatous disease, a condition characterized by a defect in phagocytic cells. Interleukins are molecules that regulate inflammation as well as the activation, proliferation, and differentiation of immune cells. The cytokines interleukin-1 alpha and interleukin-1 beta promote the activation of T cells and B cells, enhance the expression of adhesion molecules, and induce fever. A crucial step in the innate immune response involves the activation of intracellular protein complexes known as inflammasomes. These complexes serve as a link between microbial products and cellular stress, leading to the proteolytic activation and subsequent release of interleukin-1 beta and interleukin-18. The antagonism of interleukin-1, using fusion proteins like rilonacept or monoclonal antibodies such as canakinumab, is used to treat autoinflammatory syndromes, including cryopyrin-associated periodic syndromes. These conditions are characterized by an excessive release of interleukin-1 beta. One example of a treatment is anakinra, a recombinant protein that functions as an interleukin-1 receptor antagonist. It prevents interleukin-1 from binding to its receptor, thereby interrupting the cytokine cascade. Interleukin-2, also known as aldesleukin, promotes the activation and proliferation of T cells. This stimulation enhances the cytotoxic killing ability of T cells and natural killer cells. The effects of interleukin-2 are largely mediated through increased expression of its receptor on activated T cells. This cytokine is approved for the treatment of metastatic renal cell carcinoma and malignant melanoma. The cytokines interleukin-4, interleukin-5, and interleukin-13 play important roles in the immune response. Interleukin-4 and interleukin-13 drive the proliferation and differentiation of B cells into plasma cells that secrete antibodies. Specifically, interleukin-4 stimulates B cells to undergo class switching to immunoglobulin E and immunoglobulin G1, while interleukin-5 regulates the migration and activation of eosinophils. Antibodies that target interleukin-13, such as tralokinumab, work by preventing this cytokine from binding to its receptor complex and are used to treat moderate to severe atopic dermatitis. Interleukin-6 is a multifunctional cytokine involved in various processes including the production of acute phase proteins, the differentiation and growth of T and B lymphocytes, and inflammation. Additionally, interleukin-6 has a dual role in regulating insulin action. Ciltuximab, a chimeric monoclonal antibody, binds to interleukin-6, blocking its interaction with receptors. This medication is approved for the treatment of multicentric Castleman disease. A thorough evaluation of modern therapeutics must encompass a comprehensive understanding of the mechanisms underlying vaccines and cellular immunotherapies. These strategies are designed to harness the body's immune system to achieve long-term protection against disease or to completely eliminate it. Vaccination functions by stimulating the immune system to develop immunological memory, which enables the body to respond more effectively to subsequent exposures to pathogens. The primary goal is for the immune response triggered by the vaccine to mirror the response generated by natural infection. Vaccines are categorized as biological products. The main mechanism through which vaccines work involves exposing the individual to specific antigens. This exposure prompts the activation of the adaptive immune response, which is crucial for establishing long-lasting immunity. Traditional and recombinant vaccine platforms involve various methods of manufacturing vaccine antigens through genetic engineering technology. Recombinant protein vaccines are produced by inserting a segment of a viral gene into the genome of a host cell, such as a yeast cell. The modified host cell then produces the pure viral antigen, for example, the surface antigen of hepatitis B or the capsid protein of human papillomavirus. Viral vector vaccines use viruses like adenoviruses as shuttle vectors because they are genetically diverse DNA viruses with large capacities for packaging. These recombinant adenovirus vectors are capable of delivering foreign epitopes to target cells, which enhances the host's immune response to pathogens by stimulating the production of pro-inflammatory cytokines and promoting effective adaptive humoral and cellular immunity. Examples of vaccines using this platform include those developed against Ebola and COVID-19. Finally, messenger RNA vaccines are designed using in vitro transcription methods to produce transient protein expression. The messenger RNA encodes for a viral antigen, such as the spike protein in COVID-19 vaccines, and is encapsulated within lipid nanoparticles for delivery. One key advantage of messenger RNA vaccines is that their expression is temporary, as the messenger RNA degrades via cellular RNases. They also do not carry the risk of insertional mutagenesis, which can be associated with plasmid or viral DNA vaccines. The immune response is heavily dependent on the recognition of antigens. Cytotoxic T lymphocytes play a crucial role in this process, especially when combating viral infections. These immune cells identify and eliminate infected cells by recognizing small peptide fragments, known as epitopes, which are presented on the surface of cells by human leukocyte antigen glycoproteins. Additionally, immunostimulatory substances known as adjuvants enhance the immune response. For example, synthetic oligodeoxynucleotides containing unmethylated cytosine phosphate guanine motifs mimic bacterial DNA and serve as ligands for toll-like receptor 9. This receptor is located within the specialized compartments of antigen-presenting cells, such as dendritic cells and B lymphocytes. When toll-like receptor 9 binds its ligand, it activates the nuclear factor kappa B pathway, leading to the production of pro-inflammatory cytokines and type I interferons. These signaling molecules then stimulate both cellular and humoral immune responses. Cellular immunotherapies are highly specialized biological products often referred to as living drugs. They require the manipulation of a patient's own cells outside the body, a process known as ex vivo, to target specific diseases. One notable example is chimeric antigen receptor T-cell therapy, which is a type of autologous cellular immunotherapy that utilizes T cells genetically modified outside the body. The modification process, known as the vein-to-vein approach, begins with harvesting peripheral blood leukocytes from the patient through a technique called apheresis. The T cells are then purified from these blood cells and are genetically reprogrammed or transduced. This process often involves the use of viral vectors, such as lentiviruses or retroviruses, which insert a gene encoding a chimeric antigen receptor into the T cells. The chimeric antigen receptor itself is a specially engineered receptor composed of a binding domain and intracellular signaling domains. The binding domain is usually derived from an antibody fragment that targets specific antigens, such as CD19. It is genetically fused to intracellular signaling regions within the T cell, which include domains like CD28 or 4-1BB, along with a component called CD3 zeta that plays a key role in activating T cell responses. The effector function of chimeric antigen receptor T cells involves their specific recognition and binding to target antigens, such as CD19 on B-cell malignancies. Once infused back into the patient, these modified T cells activate and kill cells that express the targeted antigen without relying on the traditional major histocompatibility complex. Instead of the typical T cell activation pathway, the binding of the receptor triggers downstream signaling, which leads to the secretion of cytokines and chemokines. This process ultimately results in the destruction of malignant B cells. However, the potent activation mechanism of these cells can produce significant adverse effects. One of the most serious is cytokine release syndrome, characterized by the rapid release and proliferation of inflammatory cytokines. Managing this condition often involves treatment with monoclonal antibodies such as tocilizumab, which targets the interleukin-6 receptor to mitigate the inflammatory response. Dendritic cell therapies utilize antigen-presenting cells to activate a T-cell response against cancer antigens. One example of such a therapy is Sipuleucel-T, which is used to treat prostate cancer. This autologous cellular immunotherapy involves isolating dendritic cells from the patient through a process called leukapheresis, followed by culturing these cells outside the body. During this process, the dendritic cells are exposed to a fusion protein composed of prostate acid phosphatase and granulocyte macrophage colony-stimulating factor. The purpose of including the granulocyte macrophage colony-stimulating factor is to enhance the immune response when the antigen-presenting cells take up the prostate acid phosphatase antigen. After the dendritic cells are loaded with this antigen, they are reinfused into the patient to provoke a targeted T-cell response against the cancer. Bispecific T-cell engagers are agents that resemble monoclonal antibodies in their structure. They work by facilitating targeted killing of cancerous cells through T cells. The underlying strategy of these agents is to bring T cells, specifically those expressing the CD3 receptor, into close proximity with leukemia cells that express specific antigens such as CD19. This proximity enables the T cells to effectively destroy the malignant cells. In patient care, the different mechanisms of these agents require healthcare professionals to manage various safety considerations. Biologics, a type of these agents, interact with the immune system, which can lead to several risks. Since many biologics manipulate or exploit the immune response, they are associated with the potential for severe immune-mediated adverse events or hypersensitivity reactions, particularly with monoclonal antibodies. These monoclonal antibodies, especially those derived from murine, mouse, sources, carry the highest risk of causing hypersensitivity and infusion-related reactions. Such severe reactions during infusion are common with many monoclonal antibodies, including medications like rituximab and daratumumab. To mitigate these risks, premedication with drugs such as acetaminophen, antihistamines, and corticosteroids is often necessary, along with administering the medication at a slow infusion rate. Immune checkpoint inhibitors such as ipilimumab and pembrolizumab activate T cells, which can lead to potentially severe immune-related adverse events. These adverse events include conditions such as inflammation of the intestines, liver inflammation, skin reactions, and hormone-producing gland disorders. Often, these complications require prompt treatment with corticosteroids to manage the symptoms. Chimeric antigen receptor T cells and bispecific T cell engagers are associated with a condition known as cytokine release syndrome. This syndrome is a life-threatening systemic inflammatory reaction triggered by activated immune cells releasing inflammatory cytokines, such as interleukin-6. Treatment for cytokine release syndrome involves supportive care and the administration of tocilizumab, a drug that blocks the interleukin-6 receptor. The emergence of monoclonal antibodies targeting amyloid proteins for Alzheimer's disease represents a significant advancement in medical treatment. These therapies are notable for being the first to be approved by the Food and Drug Administration that have the potential to modify the course of the disease. Despite this progress, the use of this type of immunotherapy is associated with serious cerebrovascular risks. These risks require careful monitoring of patients and a personalized approach to decision-making. The implications of these developments extend beyond Alzheimer's disease, influencing the future development and clinical use of other advanced biological treatments, cell and gene therapies, and biosimilars. The major adverse events commonly associated with anti-amyloid monoclonal antibodies, such as aducanumab, lecanemab, and donanemab, are collectively known as amyloid-related imaging abnormalities. These abnormalities are primarily of cerebrovascular origin and can be detected radiographically in two forms. The first form is vasogenic edema, which is swelling caused by the leakage of fluid from blood vessels. The second form includes intracranial microhemorrhages or macrohemorrhages, which are small or large bleeding events within the brain. While many cases of amyloid-related imaging abnormalities are asymptomatic and go unnoticed, a subset can present with severe symptoms or even be fatal. When symptoms do occur, they may include transient and reversible manifestations such as headache, nausea, or altered mental status. Reported incidence rates from Phase 3 trials demonstrate that this is a class effect, although the specific rates vary by product. In the case of amyloid-related imaging abnormalities with edema or vasogenic edema, it was detected in 35% of participants receiving high doses of aducanumab, 12.6% for lecanemab, and 24% for donanemab. Symptomatic occurrences of this condition occurred in up to 9.1% of those receiving high-dose aducanumab and 2.8% of those receiving lecanemab. Regarding amyloid-related imaging abnormalities with hemorrhage, it was detected in 28% of participants receiving high doses of aducanumab, 17.3% for lecanemab, and 31.4% for donanemab. Symptomatic cases involving intracerebral hemorrhage larger than 1 centimeter, which occurred in approximately 0.3% to 0.6% of patients across the trials, were also reported. Amyloid-related imaging abnormalities are believed to occur primarily due to the interaction of administered antibodies with amyloid beta deposits located in the walls of cerebral blood vessels. This condition is known as cerebral amyloid angiopathy. The interaction results in vascular injury, leading to either the leakage of fluid into the brain tissue, known as amyloid-related imaging abnormality with edema, or the extravasation of red blood cells, known as amyloid-related imaging abnormality with hemorrhage. These abnormalities closely resemble inflammation related to cerebral amyloid angiopathy, indicating a close relationship between these syndromes. Several key risk factors have been identified for developing amyloid-related imaging abnormality with edema. One of the most significant is the recent initiation of immunotherapy, with most cases occurring within approximately 13 weeks of starting treatment. The presence of the ApoE4 genotype is also a significant risk factor, as having more epsilon 4 alleles increases the risk. Additionally, the baseline presence of hemorrhagic lesions, such as cerebral microbleeds or cortical superficial siderosis, suggests advanced pathology of cerebral amyloid angiopathy. Other factors associated with increased risk include higher baseline mean arterial blood pressure and the absence of antihypertensive medication use. The safety profile of anti-amyloid monoclonal antibodies raises serious considerations regarding concomitant medications, especially antithrombotic agents. The use of anticoagulants is generally advised against or should be approached with additional caution because of the increased risk of severe, symptomatic intracerebral hemorrhages. In studies involving the drug lecanemab, symptomatic intracerebral hemorrhages occurred in approximately 2.4% to 2.9% of individuals who were receiving anticoagulant therapy simultaneously. The administration of thrombolytic agents, such as alteplase or tenecteplase, to patients receiving anti-amyloid immunotherapy is strongly cautioned against. Some guidelines recommend avoiding such treatments until further safety data are available. There have been reports of fatal multifocal intracerebral hemorrhages following the use of thrombolytic agents in patients undergoing immunotherapy. Additionally, acute symptoms related to amyloid-related imaging abnormalities can mimic ischemic stroke, necessitating urgent magnetic resonance imaging to confirm the diagnosis before proceeding with thrombolytic therapy. Regarding the management of amyloid-related imaging abnormalities, the Food and Drug Administration recommends suspending doses for patients exhibiting moderate to severe findings or symptoms. Treatment may involve the use of anti-inflammatory agents, such as corticosteroids, to reduce inflammation and manage symptoms. The risks associated with anti-amyloid immunotherapy inform critical considerations for other advanced therapies, particularly regarding personalized medicine, safety mitigation, and regulatory strategy. The influence on the safety and dosing of gene therapy involving adeno-associated virus vectors is significant. Observations from toxicities associated with anti-amyloid monoclonal antibodies provide important lessons. These include the importance of understanding dose-dependent toxicity, managing immune responses, and stratifying patient risk. Similar to how the risks of anti-amyloid treatments increase with certain patient characteristics and specific therapeutic mechanisms, the safety profile of recombinant adeno-associated virus vectors is highly sensitive to dosage. Typically, high doses, often exceeding 1 trillion viral genomes per kilogram, are required for treating conditions such as neuromuscular diseases. However, such high doses have been linked to an increased prevalence and severity of adverse events, including liver toxicity and a condition known as thrombotic microangiopathy. Fatalities in some cases highlight the dangers posed by innate and adaptive immune responses, which can lead to organ failure. The risk mitigation strategy for anti-amyloid toxicity involves excluding patients who are considered high risk. This includes individuals with specific markers indicating cerebral amyloid angiopathy, as well as those with certain genotypes of apolipoprotein E. Additionally, clinical trials involving adeno-associated virus gene therapy exclude participants who have pre-existing neutralizing antibodies against the adeno-associated virus, which are commonly present in the general population. Regarding the dosing paradigm, the inherent risks linked to high systemic doses of adeno-associated virus are prompting a reassessment of the traditional approach. Instead of a single, high-dose treatment, there is a growing consideration of adopting a more gradual method. This alternative involves administering multiple smaller doses of the vector over time, aiming to achieve therapeutic benefits while minimizing the risk of toxicity. Immune monitoring and management involve the use of corticosteroids within the context of antibody-related immune responses in medical treatments. In cell gene therapy, immunosuppressants such as corticosteroids, rapamycin or sirolimus, rituximab, and calcineurin inhibitors are often used proactively to control or mitigate severe immune responses, including both humoral and cellular immunity, that can occur after administration of adeno-associated viruses. The complex safety profiles of original monoclonal antibodies, such as those targeting amyloid proteins, emphasize the need for thorough regulatory evaluation in the development of biosimilar medications. Regulatory authorities require rigorous assessment and a comprehensive collection of evidence to ensure biosimilars are highly similar to their reference products. These evaluations include detailed analytical studies, pharmacokinetic and pharmacodynamic assessments, as well as clinical investigations into immunogenicity, which is the potential for the product to provoke an immune response. Particularly for biosimilars designed to mimic anti-amyloid monoclonal antibodies, evaluating immunogenicity is of utmost importance due to the serious immune-related toxicities associated with the original therapies. A biosimilar must demonstrate that it elicits a comparable immunogenic response to the reference product. If the original medication carries risks of immune or inflammatory adverse reactions, the biosimilar is required to show similar safety characteristics in this regard. In clinical implementation, the potential for complex adverse events, such as amyloid-related imaging abnormalities, highlights the vital role of pharmacists. These healthcare professionals are responsible for leading product selection, managing logistics, and ensuring effective communication with patients. It is essential that healthcare providers trust in the safety and efficacy of biosimilars, which must meet strict approval standards. Clear and thorough communication with patients is also crucial to reduce psychological effects, such as the nocebo effect, during the process of substituting or initiating treatment with biosimilar products. The strong association between the apolipoprotein E-epsilon-4 genotype and the risk of amyloid-related imaging abnormalities illustrates the growing importance of pharmacogenomics in personalized medicine. Pharmacogenomic biomarkers are essential for predicting treatment effectiveness, efficiency, and safety, particularly as new therapies increasingly target disease mechanisms that are closely linked to genetics. This is especially relevant in conditions such as Alzheimer's disease. Small molecule targeted agents often exhibit toxicities that are specific to their class, generally due to their effects on kinase targets, which are frequently found in healthy tissues. For example, agents that inhibit the vascular endothelial growth factor, such as sunitinib and sorafenib, can cause characteristic side effects including high blood pressure, protein in the urine, complications with wound healing, and bleeding. Similarly, inhibitors of the epidermal growth factor receptor, like erlotinib, tend to produce toxicities because of the receptor's expression in the skin and mucous membranes. These side effects mainly manifest as acne-like rashes and diarrhea, and significant suppression of bone marrow activity is uncommon. Unique toxicities associated with certain cancer treatments include cardiotoxicity and veno-occlusive disease or hepatotoxicity. Trastuzumab, a monoclonal antibody that targets the human epidermal growth factor receptor 2, carries a risk of causing cardiac failure. This risk is particularly pronounced when it is combined with anthracyclines, and therefore, careful monitoring of cardiac function is essential during treatment. Another serious toxicity is veno-occlusive disease, also known as hepatic toxicity, which is associated with antibody-drug conjugates that utilize specific cytotoxic payloads, such as gemtuzumab ozogamicin. These toxicities underscore the importance of vigilant monitoring and management strategies to mitigate adverse effects during therapy. Certain biologic and small molecule agents require risk evaluation and mitigation strategy programs because they pose severe risks. For example, some of these drugs can cause fetal toxicity, as seen with medications like thalidomide and lenalidomide. Others may increase the risk of cytokine release syndrome or neurological toxicities, which are associated with therapies such as chimeric antigen receptor T-cell treatments and alemtuzumab. This content provides a critical foundation for evaluating advanced therapeutics by focusing on the unique attributes and mechanisms of biological products. Core differentiation of therapeutic modalities. Therapeutic biologics, such as monoclonal antibodies, mAbs, fusion proteins, cytokines, and vaccines, differ fundamentally from small molecule targeted agents in their origin, structure, and mechanism. Biologic products are generally large, complex molecules manufactured in living systems using recombinant DNA technology, and they naturally exhibit inherent lot-to-lot variability due to processes like post-translational modifications. In contrast, small molecule agents are low molecular weight, typically less than 1,000 Daltons, and are manufactured synthetically from chemicals. Functionally, biologics, especially mAbs, typically target extracellular receptors or circulating ligands, preventing receptor activation. They often rely on host immune mechanisms like antibody-dependent cell-mediated cytotoxicity, ADCC, and complement-dependent cytotoxicity, CDC, to exert their effects. Due to their large size, biologics often have long plasma half-lives, sometimes measured in weeks, and are administered via parenteral routes. Conversely, small molecule agents are designed to enter cells and function primarily as intracellular kinase inhibitors by binding to enzymatic ADP domains. They typically have shorter half-lives, 12 to 24 hours, and are often administered orally. Foundational immunology. The efficacy of many biologics relies on modulating the human immune system, which is organized into innate immunity, non-antigen specific, involving macrophages and natural killer cells, and adaptive immunity, specific, memory-based. Adaptive immunity is mediated by B lymphocytes, humoral immunity, producing antibodies, and T lymphocytes, cellular immunity, including CD8+ cytotoxic T cells and CD4+ helper T cells. Cytokines, including interleukins and interferons, are critical soluble proteins that regulate immune cell function and inflammation, often exhibiting complexity through redundancy and pleiotropism. Cytokine signaling frequently involves the JAK-STAT pathway. Key biologic classes and mechanisms. Monoclonal antibodies, mAbs achieve therapeutic effects through direct signal blockade, inhibiting receptor/ligand binding, and indirect mechanisms, notably ADCC and CDC. They are also employed in specialized roles such as antibody-drug conjugates, ADCs, for targeted payload delivery, and immune checkpoint inhibitors, ICIs, to prevent T-cell suppression. Fusion proteins. These engineered biologics combine functional protein segments, often using the Fc portion of IgG to impart a longer half-life. Key strategies include acting as soluble decoy receptors, ligand/cytokine trapping, e.g., etanercept for TNF-alpha, and blocking immune co-stimulation, e.g., abatacept blocking the CD28 signal required for T-cell activation. Vaccines and cellular immunotherapy. Vaccination induces immunological memory by exposing the host to antigens, leveraging various platforms like recombinant proteins, viral vectors, and mRNA encapsulated in lipid nanoparticles, LNPs. CAR T-cell therapy is an autologous cellular immunotherapy where T-cells are genetically modified ex vivo to express a chimeric antigen receptor, CAR, that recognizes and destroys malignant cells without the limitation of the major histocompatibility complex, MHC. Regulatory context and safety implications. Insulin serves as a vital example of a therapeutic protein that was historically regulated as a small molecule drug but has transitioned to the biologics pathway under the Public Health Service Act. This transition enabled the development and approval of interchangeable biosimilar insulin products, information for which is maintained in the FDA's Purple Book database. The distinct mechanisms of these therapeutic classes lead to characteristic safety profiles. Biologic toxicities. Biologics often risk severe immune-mediated adverse events, IRAs. Cell therapies like CAR T-cells and agents like BiTEs are associated with life-threatening systemic inflammation known as cytokine release syndrome, CRS, often managed with anti-cytokine therapy like tocilizumab. Small molecule toxicities. Small molecule kinase inhibitors can cause characteristic target-specific toxicities, e.g., hypertension, proteinuria, and poor wound healing associated with VEGF inhibition, due to their inhibition of multiple enzymatic sites in healthy tissue. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.